And we know that this shortfall is going to disproportionately impact rural communities. Rural hospitals are closing since 2010, something like over 140 rural hospitals have closed, and many are also operating on very, very thin margins. And we're seeing really a system that is suffering from sustained pressure, and is also still working incredibly hard to provide for its community and patients, but with these challenges of fewer facilities, fewer clinicians, and of course a growing demand for those medical services as we're seeing across the country. And that means that providers and health systems are often trying to do more with less, of course, while still trying to maintain quality access and financial viability. And I say trying, but really I mean succeeding. And we're going to hear that from so many of the speakers today about the way that they are moving forward with technology, with innovative ideas and plans, and how they are actively rethinking where care happens and how to provide that care in the most sustainable way. They are all moving beyond traditional models and into more distributed, flexible approaches. And we're seeing care extend into homes, into communities, and into places where care was never designed to be given, but are now becoming critical access points. And increasingly, we see a shift towards solutions that don't just connect patients to clinicians, but actually enable real clinical grade care to happen remotely. And this is a fundamentally different model than something that we were looking at perhaps 10, 15, 20 years ago. And today we're going to be diving in and hearing about some of those solutions that really have the potential to relieve some of the pressure on staff, to expand access, and to create something that's much more sustainable over time. And that's why we're really proud to be hosting this summit alongside the American Telemedicine Association, and to be doing this for the third year in a row. These conversations are really essential, and they're also evolving over time. When we ran our first summit, so many things have changed just in the last 2 years. And the focus is now not on whether these new models are possible, but on how to make them work at scale in the real world. And that's exactly what our speakers are doing and what they're happy to share with you today. And with that, I'm really excited to kick off with our first speaker. Alexis Apple is the Director of Federal Affairs at the American Telemedicine Association, and she also serves as the head of the federal government relations at ATA Action, which is the ATA's affiliated trade association dedicated to advocacy. And today, Alexis is going to be giving us some insights and updates to the rural healthcare federal policy landscape. Thank you so much for joining us today, Alexis.
Thanks so much, Joe, and the Title Care team for having me here today for the third annual Oral Health Summit. I think I was here last year. I'm not even sure at this point, but so much has happened since then. So I'm really excited to give an update about, federal telehealth / virtual care, both legislative and regulatory policy landscape. It's really important, and also the impact on rural health. Rural communities face persistent barriers, right? Distance, workforce shortages, limited specialty access, as Joe had outlined. So really, telehealth can help to fill some of those gaps. And that is what we have been pushing for. And we have seen, even Congress and CMS and the agencies really come to understand that without telehealth, without virtual care, we aren't going to be able to get access to care to millions of people across the country. And so with that, we're going to go to the next slide. I'm just going to quickly go over who the ATA is and who ATA Action is, for those of you who maybe don't know or aren't familiar. So the American Telemedicine Association has actually been around since 1993. So we're over 30 years old. I know it's hard to believe. People, when you say telehealth, at least on Capitol Hill, they think it was a thing that came about in 2020. And we all know that it's been around for a very long time. It just was a catalyst for change starting in 2020. So the ATA has about 400 organizations that range the gamut of the healthcare industry. Anyone who is providing virtual care services or is interested in virtual care is our member. So we've got delivery systems, we've got academic institutions, we've got technology solution providers, payers, pharmaceutical companies, and they're all committed to our vision, which is getting people safe, affordable, accessible care, effective care where and when they need it. And so that's the ATA, and that's where we do a lot of our education, a lot of our convenings. And then in 2022, we launched ATA Action. So that's our 501c6. That's where we do all of our lobbying, all of our advocacy on Capitol Hill, within the administration, and in all 50 states. I'm only going to cover federal policy today, thank goodness. I have a whole team who does the state stuff. God bless them, because it's a lot to track. But ATA Action's a little bit smaller. We've got about 50 organizations that are members, pretty similar to ATA, very broad in scope, payers, healthcare systems, academic institutions, vendors. And so very similar, just kind of focused more on the lobby and advocacy component. With that, okay, so we're going to head right into the legislative update. So what's been happening on Capitol Hill when it comes to telehealth? How much expansion have we seen since 2020? So as you all know, obviously COVID-19 really allowed an expansion of telehealth to occur, both in scope and in reimbursement. And so you'll see up here, there are some key telehealth flexibilities that were put in place back way in 2020 and have continued to stay in place mainly to this very day, and actually through the end of 2027 and through some of these other dates that you'll see up here on the screen. So I want to talk through some of those and why they're important to the rural health community. So, of course, the Medicare telehealth flexibilities, everyone's heard about these. So I'll quickly run over them just so we can do a quick refresher. But what does that include? That basically allowed Medicare patients to be able to be seen or to have a telehealth visit within their home. That still continues to this day, and that is still allowed. We did have one unfortunate lapse in the Medicare telehealth flexibilities. I'm sure you all were aware at the end of last year. For about a few weeks, which was really scary. A lot of people actually lost access to telehealth in the Medicare population. They had, cancellation of visits, rescheduling in person if they even wanted to go in person. So it was a huge chaotic moment. So to have a 2-year extension of that flexibility was huge. Another one, of course, is audio only coverage. We know how important this is, especially for the rural populations that don't have broadband access. So, right now we're doing a video visit, but a lot of times if they don't have a high enough broadband access or high enough broadband speed, they can't do this telehealth visit with their provider. So audio only is really critical in some aspects. Another key flexibility within the Medicare telehealth flexibilities, of course, was expanding eligible telehealth providers to include therapists, so physical therapists, audiologists, speech language pathologists, and audiologists. Really important that those types of therapists are able to be reimbursed for telehealth visits. Designating rural health clinics and federally qualified health centers to be distance site providers. We know that they serve the most vulnerable populations across the country. So for them to be able to provide telehealth services is huge and needs to be maintained. The removal of the in-person telemental health requirement. So for those of you who are kind of in tune with the telehealth flexibilities, so back in 2020, telemental health became a permanent part of the Medicare program. And so what that means was any telemental health service is now reimbursable for a Medicare patient moving forward, no matter what happens with these flexibilities right here. But when they implemented that, they actually said, okay, we'll reimburse for these telemental health visits, but you have to have an in-person visit first. This has yet to actually be in place because we've been under this continuous waiver since 2020. And so we've been continuing to push of how important it is that this in-person requirement never comes into place, that it is permanently waived forever, because that defeats the whole purpose of mental health, of telehealth. And we know how important, just from research and data, telemental health is across the country. People want to be in their homes when they're talking to their provider or their psychiatrist. They feel more comfortable here. They don't have to travel those long distances like in rural areas. They can be actually within their home. And I always say this with telemental health. I came from a very small town, Selinsgrove, Pennsylvania. I saw someone was from the Geisinger area, Danville. And I mean, people would know my car, right? If I went to a local mental health provider. And so sometimes people want to keep it more confidential and they want to be in their home. So it's very important that this in-person requirement never comes into place. And then also extending the use of face-to-face for recertification of hospice care. So all of those flexibilities have now been extended through the end of 2027. Huge win, 2-year extension. We were super proud of that. But ultimately, we would love to see all of these become permanent, and that is the end goal and something we are pushing for consistently on Capitol Hill. Another really impactful flexibility has been the acute hospital care at home program. This also came about back in 2020. This is a really key program that basically allows or is a critical way to deliver inpatient care within the home. And so for rural communities, it's really important, like we said, because it extends hospital capacity. So the people that really need to be in the hospital, in the ER, are there getting the help they need. But for those who maybe went through something like diverticulitis, and they're in the ED, and then they're able to be transferred home to actually complete their hospitalization. And those who are more severe are able to stay in the hospital. And so this actually allows healing within the home. You're able to receive your medications there. You're able to talk to your doctor there via telehealth. You have nurses come to see you. They also allow continuous remote monitoring within the home. So it's really important. And, this program has really shown strong outcomes. It's known to reduce cost. And so it's a very critical program that was extended for 5 years now through September 30th of 2030. So we were really excited about that. Huge priority for us here at the ATA and ATA Action as well. Another key flexibility has been the in-home cardiopulmonary rehabilitation flexibility. So just to give a little bit of background here, this flexibility, again, was initially implemented in 2020. It actually ended up expiring at the end of 2023 when the public health emergency came to an end. And so we actually lost access to a lot of these in-home programs until now. It was reinstated back in February because I think Congress realized what they actually were missing and how critical these types of rehabilitation programs occurring in the home actually are. And so this has been, again, extended for 2 years through January 1st, 2028, and hopefully it will be made permanent. And then last but not least, the inclusion of the virtual-only providers in the Medicare Diabetes Prevention Program. For those of you who may not be familiar with the MDPP program, tongue twister. This is a Medicare covered program. It's usually about a year-long life cycle designed to prevent or delay type 2 diabetes. And this program usually consists of coaching, nutrition guidance, exercise support, and weight loss strategies, right within the home now, because we actually are allowed to have virtual only suppliers incorporated into this program. And so people can receive these types of programs within their homes. And actually, the whole program can be done virtually now. So that is another, thing that was extended through December 31st, 2029. So we were excited for all of those key extensions. So moving on to kind of the regulatory landscape, the administration, and what they're prioritizing this go around. I think a lot of what they're prioritizing really intersects with rural health very nicely. So kind of before I get into the specifics of everything, I want to make one point that I think most of us can agree on, no matter, what our political views are, right, is that this is one of the most forward-thinking administrations I think we've ever seen when it comes to digital health and telehealth modernization. And so I think that we're going in a positive direction, and we're really excited. We've been, in pretty close contact with them. We made a lot of great wins over the past year already in this space. So just wanted to kind of put that out there. But with that in mind, the first major priority is, of course, technology, innovation, and digital transformation. We know that the federal government is signaling that digital tools are no longer add-ons, right? They are a core part of our infrastructure, and they can no longer be taken away. It needs to be permanently implemented. And that includes telehealth, that includes remote monitoring, that includes AI-enabled tools, and just this broader shift toward care that can be delivered anywhere at any time. Second, we're seeing a strong emphasis on prevention, chronic disease. This is so important for rural health communities. We know this, who face higher rates of chronic conditions, and they have fewer local specialists around. So again, telehealth or remote monitoring are central to moving from reactive care to proactive continuous monitoring. Third, now we're seeing a strong focus on interoperability, data monetization, and cybersecurity. As care moves more online, the administration wants to ensure that data flows securely and seamlessly between systems. So for rural health providers, or all providers essentially, this means less administrative burden and better coordination across care settings. That is the ultimate goal. I think some of the arguments we see on Capitol Hill a lot of times are, okay, telehealth is great, but how are we ensuring that patients their care and their data isn't getting siloed, right? It's not just staying with that telehealth provider and then it's going nowhere. It needs to be able to be transferred to their primary care provider or their cardiologist to make sure that they are following up appropriately. And so that is the end goal and something that we're strongly supportive of. There's also a clear focus on stabilizing hospitals and expanding care outside of the hospital, including programs like the acute hospital care at home program, like we talked about. Also through programs like the Rural Health Transformation Program that was implemented in the One Big Beautiful Bill, which essentially is a $50 billion program aimed to help rural health hospitals, rural health providers. And so we'll see how that program kind of pans out. We have been closely tracking that program. It's mainly occurring kind of at the state level. And it's really up to the states to determine how those funds are going to be allocated. So it'll be interesting to see how that all plays out. But we have been encouraging states as well as CMS to ensure that telehealth and technology is incorporated in that program. And so we will continue to keep you updated there. Also, affordability, access, and patient choice are also front and center. The administration is looking for ways to reduce cost barriers and expand the range of care options available to patients. And we know telehealth is a major part of that strategy. And then finally, I think this is one of the biggest ones, especially to the rural health community, is workforce expansion through telehealth. And we know with persistent provider shortages, telehealth really becomes a force multiplier. That's what we say all the time. Between virtual supervision, remote consultations, and digital health tools, all of these really help to extend the reach of clinicians and support team-based care in places where staffing is just stretched way too thin. So overall, I think these priorities are pretty closely aligned with what rural communities need: more access, more flexibility, and more modern tools to deliver high quality care. So I thought this would be a good segue into the CMS physician fee schedule, something that the ACA, and I'm sure many of you closely track every year. This occurs annually, and it's a very important fee schedule. It really sets the standard, I think, for all payers across the country. They all look to CMS to see, what are they going to cover this upcoming calendar year? Who's going to be included in that as far as what types of providers? And what types of services really fall within that coverage, and what are the reimbursement rates going to be. And so last year, in the calendar year 2026 physician fee schedule, we had a lot of huge wins in the telehealth community. I think this was one of the first real permanent ways that we have seen this administration really focus and prioritize telehealth and virtual care. A lot of these flexibilities that have been made permanent were initially implemented in the COVID-19 era as well. So just wanted to preface with that. But you'll see up here, like, the direct supervision for all services has been made permanent. That's huge, especially for rural areas. They're also continuing to allow teaching physicians to have a virtual presence in all teaching settings. So that's really important. That was a big flexibility for many of our members across the gamut. There is the expansion of the remote patient monitoring and their remote therapeutic monitoring codes. So previously there was a 16-day data requirement. I'm sure many of you are aware of this. So basically, a provider had to track a patient's data for 16 days continuously over a 30-day calendar period. If you did not hit those 16 days, you didn't get reimbursed. And so they realized that, first of all, 16 days is very arbitrary. And in some cases, in some conditions, that's way too long. And the data is just actually at that point not even relevant. And so CMS recognized that, and they ended up creating a 2 to 15 day code for that calendar day period, which was really exciting to see. Something we advocated for years. So to finally see that to come to fruition was really exciting. Of course, permanence of all the Medicare telehealth codes on the Medicare telehealth list, huge, because like I said, they all came about in 2020. They've all just been temporary. And then finally last year, CMS made all of them permanent. They removed all of the telehealth frequency limitations for those types of visits that you see outlined there. Another huge win. And then also they have permanently allowed providers who render telehealth services to use their affiliated practice address rather than their home address on Medicare billing and enrollment forms. I know this sounds like a very weedy kind of one-liner here, but that actually is a very, very, very important flexibility to many of our members. They actually said that if they were not allowed to use their affiliated practice address and they had to use their home address on all of these forms, it would be a huge burden. And many of them would stop providing telehealth services. They actually said that this would be even more significant than a lapse in the Medicare teleflexibility. So we're really excited to see that CMS recognized how important this was and essentially made it permanent. And we'll move on. Another really important flexibility that I wanted to bring up here, because I think it really impacts the rural health community, is the remote prescribing of controlled substances. So just to go back really quickly, this initially was implemented back in, or stemmed from 2008. And there was a bill called the Ryan-Haight Act. And this essentially implemented an in-person requirement anytime a provider wanted to prescribe a controlled substance virtually. And so that in-person requirement was in place for a long time. And then 2020 came around, right? And they ended up waiving it because they said, hey, we need to get people access to their prescriptions. They can't go in person anymore. And so now we understand telehealth virtual care is really important. So they ended up waiving the in-person requirement temporarily. It has been continuously waived since 2020 up until this very day. That flexibility has been extended through the end of this year. So come December 31st, 2026, it is set to expire unless the DEA extends it, the Drug Enforcement Agency. We do anticipate that they will either extend it again or come out with some permanent solution. Something that we've been particularly advocating for over the past few years is basically an implementation of a permanent and workable special registration process within the DEA. So what it could potentially look like is the DEA would put out this special registration process, and providers who want to prescribe controlled substances could apply for it. Nothing too overly burdensome, but could apply for it. And then they could essentially prescribe any type of controlled substance across the country. That's kind of like our goal and our hopes. And so we've been working with the DEA and the administration on this, and we are making some headway. So stay tuned for more there. But this is really exciting because we need to ensure that people can continue to get their prescriptions, whether it's virtually or in person, anywhere that they're located across the country. And so that is a very key flexibility for us here at the ATA. On to the next slide. What I couldn't not talk about AI and wearables, especially in this day and age, and it's been a hot topic now for how many months, and we know that this is essentially emerging federal policy. And there's been a lot kind of happening actually then historically at the federal level when it comes to AI than normal. Usually we see a lot of action at the states, and we have seen a lot of action when it comes to AI within the states and them regulating AI, specifically in healthcare. But we have also seen the president even take some action recently on artificial intelligence, right? So he released an executive order in 2025. I think one of the biggest things that came about that was that they are pushing for federal preemption. So basically some sort of federal framework for artificial intelligence. That way there's not all these, sporadic state laws that all these providers have to keep track of, hospital systems have to keep track of, because it's just not feasible. And essentially, I think it prevents people from adopting these AI tools. And so that is one of the biggest developments that I think that we've seen come out of these executive orders. We've seen come out of these federal regulatory frameworks. Just last week, like I said, the president released his federal regulatory framework on AI, and at least the biggest component of that for the healthcare industry, I believe, is that they are in support of a federal preemption regulatory framework. So they want to see the federal government, do something on AI that everyone has to follow. There's also been a strong focus on wearables and remote data. Everyone at this day and age has either a Whoop, an Oura Ring, an Apple Watch, right? We know how important these devices are. They really track, how human beings are living their daily lives. And they really give us key insights as to how we're sleeping, how we're recovering, how much stress we have every day, and our overall health. And they really can be used to prevent chronic disease, maybe to catch a disease or, catch something in advance, which is really what we need. And I truly believe that, CMS needs to come up with something to either reimburse for these wearables or encourage, people to wear even more of them. I think it was Dr. Oz who said he wants everyone to be on a wearable in the next 5 or 10 years. I don't remember exactly the quote, but I can see we are moving in that direction. And I think it's very positive. Without technology, we're not going to get there. And like I said, wearables, remote data, but especially wearables, they're expanding the use cases in care delivery. So like I said, wearables aren't just tracking fitness trackers anymore. They do so many other things. They track your sleep. They track menstrual cycles for women, which is huge. Things that really we can take a look at a broad level and say, okay, what's really going on with me and how can I get help? What can I tell my provider? I'm not getting enough sleep. What does this mean? Why am I not getting enough sleep? Why am I having a trouble sleeping? So I think it's really important. I think it's something that we're going to see more regulation around, more reimbursement pathways around when it comes to AI and wearables at the federal level. So it's really exciting overall. And with that, I think we can go to the last slide. So overall, what does this long PowerPoint mean for rural Americans? So I put up 5 words here that really came to mind when I thought about it. Access, right? So care delivered in the home, regardless of geography or broadband strength, audio only. Choice. So patient choice, more provider options, including virtual only programs, huge. Quality of care. Remote monitoring and AI tools support earlier detection and better outcomes. We know this. Innovation. Federal policy is enabling new care models like hospital at home and new technology-enabled care and devices. All things that we need. Without innovation, we're not going to help. We're not going to get to full prevention. We're not going to get to earlier, diagnosing of chronic conditions. And then, of course, vitality. So this really strengthens rural health systems, and it keeps the care local, which I also think is huge. It's just keeping your care local as much as possible. And so those are kind of the 5 words that I kind of thought of when I went through this presentation to kind of wrap up and think about how this federal landscape is intersecting with rural health. And I think it's all very positive, and I think we're heading to a positive direction. So with that, Joe, maybe I'll turn it back over to you.
Thank you so much, Alexis, for those insights. And thank you for sharing your email. I hope we didn't speak about this, but hopefully you'll be able to stay for the roundtable. And if anyone has any specific questions, they can ask you then, or be in touch with you directly. I think, you kind of mentioned something that we've been working on really hard with some of our partners here is the Rural Health Transformation Fund. We actually have put a guide together. I will kind of just note this was kind of more in the pre-December kind of application phase. But there's going to be a poll popping up on your screens any minute now. And if you do want to receive that, please let us know. Know that this is something that we are working on very closely with a lot of our partners. Obviously, as Alexis mentioned, the Big Beautiful Bill came with many shifts and some kind of cuts there as well, which hopefully the Rural Health Transformation Fund will help to start reimbursing for some of those. And we know that some of our rural health partners definitely have some challenges that they're going to be facing with regards to the cuts, with regards to the fund. As I mentioned, we have been working with our partners on a lot of those questions as well. So if there's anything that we can do for you at TytoCare, just let us know. We would love to work with you on that, whether it's an application to the state or some kind of broader questions and answers. And don't forget, if you do have any questions for Alexis here or any of our speakers today, you can put them in the Q&A box. And we will go through those in the roundtable at the end of the session. Now I'm really excited to introduce our next speaker. Mark Powles is a customer success team lead at Sanford Health, the biggest rural health organization in the country. Mark is working on driving adoption and success across the organization's virtual care initiatives, which are incredibly broad. Mark has implemented more than 200 virtual care delivery projects. Mark, thank you so much for joining us here today.
Yes, thank you, Joe, and thank you everyone for joining us here. Happy to get to share a little bit of Sanford Health's virtual care story. So we can flip to that next slide, and I'll just start off with who we are at Sanford Health. I was looking at the chats, and I see a lot of people are from the East Coast, West Coast, down South, so happy to say we're good old Northern Midwest up here. And yes, we are the largest rural healthcare system in the United States geographically, 57 medical centers, just under 300 clinics, 150 senior living, et cetera, et cetera. We ultimately care for over 2 million people across the Northern Midwest. Additionally, we do have our Sanford World Clinics that are located 2 in the United States and then 4 out. Oh, sorry about that. Other than that, we are the largest employer in 2 of our 5 state footprint today. We have integrated health plans with our Sanford Health Plan in our current region, and then we recently merged with Marshfield Health in Wisconsin and Northern Michigan to add Security Health Plan as well. So both all integrated now together as one Sanford Health system. Rest of the slide touches on how many people are involved in it, and it's a lot. So we're happy to be a strong player here in rural healthcare. So with that being our global Sanford Health lens, let's dive into virtual care a little bit more specifically. So at Sanford Health, we have our vision is to be the premier rural healthcare system. We're already the largest, but we also want to be the best. So being premier is the vision. And so the way that virtual care kind of attributes ourselves to that vision is to bring affordable, comprehensive, high quality care to people regardless of their zip code. And so virtual is a great way to do that. And we'll be touching on that basically for the rest of the presentation. So on to the next is just a touch on Sanford Health's investment in virtual care. So prior to 2011, virtual care was kind of seen as an adjunct to healthcare. We were an IT department. We just kind of produced technology and left it to providers to say, here's a toy, go ahead and play with it if you'd like to. So 2011 was actually when we started as an official department, starting with an emergency service that we stood up through federal funding, providing 24/7 birth certified emergency physicians and nurses. I don't want to go through this entire slide. We've done a lot of things over the past few years. But biggest thing here that I want to touch on is obviously no virtual care story is complete without COVID-19's investment in us as a service for providing virtual care. It was a disruptive experience, but because of that, it really was an explosion of what virtual care can do. And it really sparked a lot of innovation across Sanford teams and everyone beyond that outside of us as well. Other thing on this slide, don't worry, you have to go back. 2024, we launched our virtual care center. So it's our state-of-the-art facility for innovation and delivering virtual care. I am here today presenting from here. So I just want to give a call out that that is something exciting that is new that we've done recently. So, all right, on to the next. For the bread and butter, if you will, of our virtual care services, going back to 2011 to today, has been clinic and hospital services. What these entail are patients presenting to their local facility for a scheduled visit connected virtually. So all kind of detailing back to pre-COVID days, this was kind of what we were able to do that was approved by CMS, reimbursable, et cetera, was the patient would present to a healthcare facility, just not where the provider was located. And so with that, we had a telepresenter, which would be a nurse or aide at the OS site, who would help that patient get connected to video. If they had a peripheral available, such as TytoCare, they would help assist with that examination directed by the provider at the DS side. And really is vital for keeping dollars local, as well as diminishing that travel time and travel expenses. So overall, we do a lot of behavioral health here, dialysis care that we're able to do rurally. Infectious disease does quite a few consults for inpatient and outpatient. Then we do have telehospitalist and hospital at home services as well. Here is a map of all of those clinic and hospitals that we deliver care to today. There's 113 on here last time that I counted. And they all are equipped with a TytoCare device, access to our Epic platform, and they're able to connect to our providers for a bunch of different services. This next slide will touch on kind of a glimpse of what that looks like with us delivering 80 plus different specialties to all of these sites. 113, it's 110 plus on here, but I promise I counted 113. Since 2011, saving over 60 million miles of travel time. For volumes, those are all the different ways that we've broken down how we deliver care today. So verbal visits are those audio-only phone call visits. E-visits are an acute care service where a patient fills out a questionnaire and receives care asynchronously with an acute care provider. Video visits is anything we do that involves video. So all of those rural sites that host patients, those video visits roll up here. Any direct consumer video visits that we're doing where we are providing behavioral health services direct to home, et cetera, all of those would be counted up there. ER visits, so all those visits set up through that 2011 grant, still going strong today. Big focus there is our telestroke and telebehavioral health services. They amount to a great proportion of those ER visits and making sure that those patients that are suffering from those conditions are able to get the help they need properly at their rural facility and expedite transfer if it's necessary or prevent it if we're able to. MyChart Messages is also a new thing that we have started to apply to our providers. Many of our providers receive hundreds of MyChart messages every given day. And for them to take the time to respond to all of them is quite taxing. It also takes up a great deal of their time. And so we are able to flip a MyChart message if it's going to take a significant amount of a provider's time to answer that question. They can actually convert that message into an e-visit, which then kind of creates that questionnaire model where they're able to fill in the questionnaire, send it to the provider, then provider can give their diagnosis, send a prescription, et cetera, and bill accordingly. So it's a great way to recoup some of that revenue they otherwise may have lost. Overall, we did just hit our 1 millionth visit this past October, so very excited to be on our way towards that 2 million here. All right, here is a glimpse at all of the services that we have today. We'll just touch on one for each thing. So starting in the bottom left, we have consumer solutions. So that's all the virtual access that we have for patients at home. Video visits are the most commonly used in this instance. Behavioral health, obviously very important. We really want to use consumer solutions or direct to patient home care for any visit that does not require a physical exam. So behavioral health is the #1 option there since it is truly just a conversation mental exam. But there are other utilities as well for some acute care needs and things like that. Clinic solutions, able to do that for when you do need that physical exam, but you do not need it to the extent that you have to put physical hands on the patient. So those are powered through TytoCare device peripheral examinations. You have a nurse on site who's collecting vitals and all those sort of preliminary information, but still able to provide the care that you need to through a virtual modality. HOD inpatient solutions are doing video visits to a local medical center. So big thing there is specialty consults for providers that are able to do that for patients that are in inpatient facilities in rural America. Biggest one that we do today is infectious disease. For quite a few facilities, we are their infectious disease care that they get while they're on that in that inpatient stay. And so happy to provide that from our hubs here in Sioux Falls and Fargo. Emergency solutions, kind of alluded to this earlier, but we offer trauma, stroke, burn, and behavioral health services. The two strongest there are stroke and behavioral health. For these rural hospitals that could simply not afford a neurologist to be on call 24/7, we are able to provide that virtually. And it's the difference between a patient presenting to their rural clinic with stroke, having to get transferred to us 2 hours away, and them not being outside the window for TPA or any of some of those life-saving block clustering medications. And so being able to consult on those patients rurally and then give that medication is the difference between life or death in some cases. And the other being behavioral health. We obviously know there's a great burden of behavioral health, especially in rural America. When a patient presents to the ER for behavioral health, there's not always a physician on staff who feels adequately trained to care for that patient and or comfortable to do it. And so being able to supply a board certified psychiatrist to those ER facilities is a great resource for them to be able to get the patient the correct, adequate care that they need, and also get that recommendation for further care. So whether that is admission to an inpatient behavioral health unit or otherwise. And lastly, business partners is just kind of a round out for all the different services outside of kind of the traditional healthcare model where we provide services to. Most common one would be senior living facilities. We recently launched the My Care line is what we refer to it as, but it is a nurse triage line. It's able to assist skilled nursing facilities with determining what they should do with their residents. So whether that is being able to advocate for them to come into the ER if it's appropriate to do so, versus giving them some advice, connecting them to a primary care provider who can help in that instance virtually, and things like that. So really, it's a great service to keep residents in their facilities where they're the safest. As we all know, there's great risk that comes with leaving the facility for any healthcare need, especially for us up here in northern Midwest where we are deep in the snow age right now. All right, so with that, that's kind of my long story short of Sanford Health and virtual care today. So now for the topic of my actual talk, which is kind of our story of growth and what we're doing as ways to meet some of those workforce shortages. So overall, our story begins with 2011 again. The foundations of virtual care really helped us when we get to stage 2. So we really established virtual care as an independent department, which again, separate from IT. We launched new services via organic, internally funded planning and our federal grants. We are very blessed to have a gracious benefactor in Denny Sanford, who Sanford Health is named after, who does quite a few initiative work across healthcare. He's one of the most generous benefactors of healthcare ever. And so he has been very instrumental to our growth from the get-go. But the biggest thing that we can for a takeaway for our story of growth from the foundation stage is getting those standardized workflows for each use case. So that clinic to clinic, clinic to hospital outpatient, clinic to inpatient, our emergency service, et cetera. Getting those workflows created and standardized has been monumental in what came in 2020 when there was the pandemic explosion. We saw a 10,000% growth in 2020 through ultimately forced adoption. And really what that did is it proved that virtual care is a feasible way to deliver clinical care. And so with that proved feasibility and the foundations that we had that made it easy to adopt, we really were able to spark some innovation amongst our clinicians, and they were able to start thinking, I have this huge demand for virtual right now. Maybe I should capitalize on this and turn it into a real program. And so that was kind of the shift we made near the end in 2022 or so, was shifting from that reactive demand to a deliberate program management. Which brings us then to our current state where we reside today, which is the clinician-driven model. We continue to maintain our existing services. As a customer success strategist, we have 170 different touch bases that we need to do in order to care and touch all of our different users of virtual care, whether it's the provider side or patient side. And so we do that dutifully in order to make sure that virtual care is running smoothly, the providers have what they need and are getting value from the service. We also meet with service lines to promote and advocate for virtual use as an option, really just sharing that any visit where no physical exam is needed can be done to a patient's home virtually. If there's long travel needed for a patient to come see you, consider if there is the option to have them present to a local site to be telepresented at. And really, when we bring any of these promotions, advocates for clinicians, we wouldn't be able to do it without sharing numbers. In our experience, that has been the most effective way to really reach that population. And so the number that's been really driving us lately is that in 2025, we saved providers and patients over 18 million miles of travel time. And we had some people better with numbers than I run the numbers, and that equates to over $40 million saved in fuel, lost wages, ancillary travel expenses, potential overnight stays, et cetera. So $40 million is a great number to put in someone's face when they're saying, I don't think I want to do this. All right, so with this is my plug for our Sanford Health satellite clinics. So what a satellite clinic is it is a way to meet workforce shortages in rural America. And so satellite clinics are staffed not by a provider, but by a nurse and or LPN who is able to provide multiple services at once for that patient without a provider on site. So things like nurse-only visits for immunizations, blood pressure reads, et cetera. Being able to be the phlebotomist who might pull some labs and being able to then also run the labs on the same facility. And so with that, we really have a unicorn, jack of all trades employee there working the clinic. And the provider group is in one of our urban hubs, which urban for Midwest is kind of an oxymoron, but for us, that means Fargo and Sioux Falls being able to provide primary care, acute care, and a few specialty cares directly to these satellite clinics. So our first one went live in Lidgerwood, North Dakota. That one is a satellite clinic for 2 days a week and then has a provider on site for 2 days a week. But it is a great service for them to be able to get that ongoing patient care, doing it in a cost-effective way, as if they were open 24/7 with a MD provider on site at all times. It would no longer be break even for that clinic and would likely have to shut down. So satellite clinic was a great way to keep that clinic open and operating today. The next three are all kind of a pivot from that model from rural access to rural access in the sense that there isn't another option for healthcare to rural access for vulnerable populations. So our preventive care line allows us to help out our MA and ACA members for our health plans. The My Care line I touched on earlier is for those senior living residents to be able to receive the care they need right where they are. Lifescape is a pediatric complex condition management facility. Kiddos can stay there for inpatient stays, or they kind of live there as well for some sort of intermediate care where they're commonly needing to get healthcare. So we're able to equip them with all the resources they need to do a virtual visit with providers as well. And lastly, we have our next satellite clinic picked out, just working through the different pieces of it, but it will be in Pittsville, Wisconsin. So a quick plug for our recently merged with Marshfield Health System. Pittsville is a community that does not have a pharmacy within 80 miles. It doesn't really have a great healthcare presence currently. And so a satellite clinic will be a great opportunity for us to give that population access to the healthcare they don't currently need, or they don't currently have, but desperately need. And with that, that is the end of my talk. So very happy to have shared this all with you today and looking forward to the roundtable at the end.
Great, thank you so much, Mark. That's such an impactful, the last slide that you had, the name of it has gone out of my head, the satellite clinics. Sorry, not enough sleep and not enough coffee. Yeah, that's such an impactful project. Is the plan to scale that dramatically, or is the plan for that to kind of slowly grow over time?
I think for the most part, it's planning to slowly grow. We obviously would be open to launching them wherever they are needed. And we do have quite a bit of interest around our rural population, our rural areas that want a satellite clinic because they want a Sanford presence. They understand they can't do it all the time. So this is a great model to get them Sanford if they want Sanford.
Sure. No, that's fantastic. Thank you so much for the presentation. I can't wait to the roundtable because I have about another 50 questions for you. So to all of our audience, get in your questions now. Otherwise, you're just going to have to listen to me pester Mark the whole way through the roundtable. We have actually also worked with the team at Sanford Health to put together a case study about some of the work that they're doing to advance virtual care in rural areas and how they're using TytoCare to do it. One of the, Mark, one of the calculations that you mentioned, around $40 million saved, that was, I think we have a slightly different number in there because it was just based specifically on the journeys that Tyto had been involved in. But if you do want to take a look at that case study, we can send that through to you after the event today. The poll has just popped up on the screen, so just let us know there if you are interested, and we'll send that over to you. I'm excited and looking forward to introducing our next speaker, Lacey. Lacey Finkbeiner is a clinical informatics specialist at Horizon Health. She's been working in rural healthcare for over 15 years at FQHCs. And today she's going to be talking to us about some of the challenges that the rural healthcare programs face and how the programs need to be rooted in resilience to succeed. Thank you so much, Lacey, for joining us today.
Yeah, thanks, Joanna. Thanks for having me. This is our second year presenting in this, so it's exciting to see this virtual summit continue to grow, and interesting to hear all of the different dynamics that the speakers have to offer. But yeah, like Joanna mentioned today, I'm with Horizon Healthcare. We're an FQHC in rural South Dakota. So just like our previous presenter had shared, we're in the Midwest, pretty rare out here. So Horizon serves the healthcare and dental needs for South Dakota for over 80,000 patients. We've got a vast statewide footprint. We do have 27 medical clinics and dental clinics in our communities in Aberdeen, Alcester, Bison, DeSmet, Eagle Butte, Elk Point, Faith, Fort Thompson, Howard, Huron, Isabel, La Plante, which is a school-based site, Martin, Mission, Plankington, Wessington Springs, White River, Woonsocket, and Yankton. You could essentially write a song with that. Our organization does employ over 300 professional staff members, and we do offer 3 different service lines to the rural frontier communities. So we do offer medical, dental, and behavioral health services. So that's just a little bit about us in our footprint. So we've been actually doing telehealth for close to, I'd say, 25 years, if not a little bit over that mark there. So we'll have you, Becca, go to the next slide here. I think actually, so I just did that one. So jump to the next one if you would. Perfect. So just a little bit to talk about our first service line of medical. We've dabbled in telehealth, like I had mentioned, for 20 plus years. In our early years, we were mainly focused on that specialty and acute care. Through technology, it was very expensive. It was bulky. The connectivity was very limited for some of our locations. Within the last 10 years, especially during the COVID pandemic era, the pathway of what telehealth looks like has grown drastically. The capabilities have allowed our patients to receive healthcare when whether absence prevents them from seeing a local provider. In the case where our provider is absent in our clinic, we use telehealth for that overflow situation. Our clinics also have the ability to connect to specialists from Avera, from Stanford, and as well as Monument Health. Instead of driving hours to see that specialist or that dentist, they can conference in with one of our providers as well to use that telehealth dynamic to save time and a hassle as well to cut back on that mileage. During the COVID pandemic, we did offer the telehome services as well for our medical service line, but it has slowed down quite a bit since then. The need of getting the patients back in the door has seen a greater benefit than using the telehome services. And we continue to use that in-clinic telemed for the coverage for the clinic absence and so forth. So at this time, though, we are looking to revisit the need for telehome because it is starting to pick up again, though. So on the primary service care line, that is something we're looking into because there's a gap of care for our population. And if so, that's something we're looking at rolling out as part of our strategic plan in the coming years. Our next service line is dental, of course. So this, with our dental clinics, we are very, very spread out. Our mileage between dental clinics, you're looking at least an hour to get to each site, if not more. So we offer teledentistry services. So where this is, it's kind of a unique setup. Our hygienist is able to connect to a dentist at a distant Horizon location and present that patient for their routine examination, or if they've got an acute oral injury, or if they need to get them started on an antibiotic or whatnot, to prep that patient for their treatment plan to start that next process to get them that intermediate care when they need it. And then we'll work to schedule them with the dentist as soon as we can get them on site to that dental facility. So because we are so spread out, this has helped with our dental coverage and our staffing, allows us to keep those clinics open while providers are maybe out on an extended leave or maybe out for just a day or even for that overflow coverage. And like I mentioned a little bit ago, our third service line is behavioral health. So Horizon originally offered BH services for established Horizon patients only at the beginning of the creation of our program. So we used internal referrals from our providers to build that BH program. A lot of our BH patients are seen via telehealth. We do have some providers that are on-prem that are seeing patients face-to-face, but majority of the visits are being done virtually. In the last year, we have rolled that out and expanded to opening our service to non-established patients to expand the volume. This has allowed us to increase our staffing with nurses, providers, and continue to build that program. Majority of our visits are conducted via telehealth for convenience and confidentiality. Just like the other two presenters had mentioned, having that access from your home, more patients are apt to commit to those visits, stay on task to those visits. Your no-shows decrease because their comfort level is joining from that home site or that facility where they can. They don't have to take off work to go to travel to a facility. Patients can opt to be seen via telehealth. We did just transition to Doxy, that platform. We were using WebEx. We found great luck with the connectivity of Doxy, the patient accessibility of using it. They can quickly receive a text, jump on to their visit and see their provider. Or they can come into the nearest clinic and connect to the provider using our in-clinic telemed equipment that we have. We are currently transitioning to a new platform there as well this spring, so we're excited to see how that rolls out. Currently, we use WebEx for that, but we will be moving over to Teams eventually here. And then the majority of our behavioral health providers do work remotely. So this has been a benefit in recruiting to build the team. They are spread out across the state. It is difficult to hire individuals in our small communities with that specialty. So this has been nice to allow these providers to work from home and still see our patients in our vast coverage area. Becca, I'll let you go to the next slide, please. All right, so Horizon has been a leader in telehealth since the early 2000s in the FQHC world. As technology has evolved, access to the telehealth visits have continued to expand across our organization. In the last 3 years, we've seen considerable growth. And in past few months, just into 2026, we're already trending towards increasing and blowing our 2025 telehealth visit numbers out of the water. So just having that access to the care and the access to technology, the patients are utilizing the services. We're continuing to see that growth and that patient buy-in as well. So I'm going to actually present and have Becca share a little video with you guys about our teledentistry program because it is unique and how it works here at Horizon. So many of our dental clinics, are, like I mentioned, are located at least 60 miles apart, which can make it challenging to provide consistent provider coverage. We found that it's a staffing barrier because of the distance between the sites. Recruitment is very difficult and so forth. So being able to use teledentistry to provide that timely care has been a highly effective solution for many of our locations, and it helps us bridge that gap between our patients and our community to provide that continuity of care. So let's watch a short clip of our dental officer, Dr. Michelle Schultz, on how our teledentistry program works in our clinics. And it might not play.
Becca's just lining that up. I just wanted to ask, in terms of teledentistry, do you see when a patient then needs perhaps some kind of procedure, or how quickly are you then able to get them over to a physical facility for them to have that follow-up or have that physical care that they might need?
Usually it's within the next week to 2 weeks based on the provider's schedule. Or if we have a dentist, we can get on site to see that individual. So usually they're looking at the next available appointment and trying to work those individuals in. If we can't, then it's a referral out to another entity, whether it's in Rapid City, Bismarck, Sioux Falls, etc. But they can at least get them initiated on progress.
I'm the Chief Dental Officer with Horizon Healthcare, and we're here to talk a little bit about teledentistry and some of the exciting things that we've been doing the last couple of years since COVID hit. Teledentistry is where we have providers at one location and the examining dentist at a different location. And we use just a couple simple things. So we use our computers, just a laptop. So the dentist and the hygienist will have their laptop and they'll connect via a meeting, like a WebEx meeting or a Zoom meeting. And then the hygienist at the site with the patient will use just this intraoral camera that they'll connect to the computer. And then they'll go around tooth by tooth, showing the dentist exactly what is in the patient's mouth so that we can do a comprehensive exam for the patient. We found the teledentistry to be very beneficial for the patients and for the providers, because this allows the patients to meet with the dentist the same day potentially and create a treatment plan. And so that when they come back for their next appointment, they already know what they're going to have done. With teledentistry, we've been able to increase our access to care to patients. Being in South Dakota, it's a very large rural state, and recruitment for providers is very difficult to do sometimes. And so by being able to have this basic technology, we're able to provide more access to people in all corners of the state.
Perfect. Thank you, Becca. If it goes to the next slide here.
Hello, I'm Dr. Michelle Schultz. I'm the Chief Dental Officer with Horizon Healthcare, and we're here to talk a little bit about teledentistry. And so
there we go. Okay, so how has the telehealth programs impacted us in our patient care? With patient education and technologies used during acute and primary care visits, specialty care, the impact of using TytoCare platform for our primary and acute and specialty care has been a game changer. Now to kind of talk about our service line with the medical side, we use TytoCare for our connectivity for our acute patients. The technology that TytoCare offers, it's easy to use, it's affordable, it's versatile, the heart and lung sounds, the vitals, general exam, CAM, the ENT view. Our providers have seen great luck with connectivity of using these devices to do that exam on those patients and get that full comprehensive view. Having this coverage, it allows less travel time for our providers. As I had mentioned earlier, a lot of our clinics are greater than an hour apart. I'm up here in the northwest part of the state, and we drive at least 50 miles to the closest clinic or the closest big town. I'm in a community of 125 people exactly, so pretty small. So most of our clinics are being run by a very small care team, provider, nurse, front desk style. In those cases, if that provider needs to be gone for a day or has a leave of absence or a week off or whatnot, telehealth has become a root in our main operation structure to be able to provide that gap in care for our patients. It takes nearly 2 hours to even get to a specialist. So if we're looking at going to Sioux Falls from where I'm at, we're looking at 5-6 hours. So we've been able to utilize the use of TytoCare to connect to those specialists as well to eliminate that extended travel time, that gas money, that hotel stay, and so forth, where it allows people to stay in their town, stay in their community, and we're still able to get them connected to receive the care that they need. By performing the telehealth coverage, it keeps our clinics local while we're able to provide services and covering another clinic. We actually do have a clinic which is 60 miles away from me here that does not have a full-time provider. She only goes there physically 1 day a week. The rest of that, they do solely telehealth visits. So they're still averaging to see 8 to 10 patients a day by keeping that community and keeping doors open. They run 2 nurses and a provider there, or 2 nurses and a front desk there daily to provide that access to the community. And they know that they can connect to their provider when they need it, the drop of a hat, using the TytoCare technology. We've seen a patient satisfaction increase. They appreciate the access to the different specialties that we have in our communities, along with having the ability to stay home in their rural community without having to drive to an hour to the ER or 2 hours to urgent care. So that has been a nice change. And then we do have one more video I'm going to share with you of what that kind of looks like on the acute side. This is the community that I was talking about. This is our Bison Clinic. So it's a 4-day-a-week distance site location where the provider actually is in the office that I'm currently in and connects to them. And you'll see the 2 nurses kind of explain how that works and how that has kind of saved the care in their community. So I will let Becca play this last video here, and hopefully it works.
I'm gonna just jump in because I think that the video connection is not working quite as well as and I want really everyone to really be able to appreciate, because I've seen this video and what they're doing is really, really cool. And I know we've spoken about this as well. I know how well it's really serving the community there. So what we will do is in our summary emails at the end, we'll send a link to this video so that everyone can watch it, which I think is going to give them a chance to kind of make sure that they really get the benefit of what they're talking about here. Is there anything specific? Because I know that they're speaking about, you mentioned the clinic is open it's 1 day a week with a clinician, and the rest of the time it's serviced remotely. Is that right?
Yes, that's correct. They have 2 nurses and a front desk staff that are there the 5 days a week, and the provider does go physically on site 1 day a week.
Okay. And then if that provider, obviously, if there's specialty care required, can they then also do that remotely from that clinic, or is that something that they would then? Okay, amazing. So we're saving hours. I mean, I'm not doing anything.
Yep.
You're saving hours and
You
hours of travel and of inconvenience as well for the patients.
Yes. And essentially we're still keeping the doors open in 2 of our facilities because that provider covers the main clinic that I'm currently in 5 days a week as well. So when she is gone there on that 1 day a week in the Bison Clinic, we use telehealth to connect to her from my main community here. So we're not shutting the doors down. We're still providing that access, still having that nurse and front desk on site those days where we can still work as a care team to get those patients seen.
I think that's really interesting. It ties in really nicely to what Mark was talking about with the Sanford satellite clinics as well. Yep. So this is a model that we're kind of now seeing come up a few times, and I think there's another presentation that's going to kind of address this as well, which is a really interesting way to resolve those workforce shortages, keep patients with access to care as often and as at a higher quality as possible. So just for everyone listening, you're going to get a link to this video. I'm sorry, Lacey, that we're having those technical difficulties, and I'm going to butt back out of your presentation. And
you're okay. You're okay. That pretty much concludes kind of what I had to talk about. I will be available during the roundtable, so if anybody has any questions, as Joanna had mentioned, put them in the chat. It's nice to see and hear from everybody across the country and the world, and see what you guys have going on. So again, thank you for having me today and getting a chance to hear about our story of how we weathered the storm and using the telehealth capabilities to provide that patient care in our rural communities. So again, thank you.
Thank you so much, Lacey. And I want to also just take this chance to mention our podcast. It's called Access Amplified. And Lacey has been one of our guests. The podcast focuses on how digital health is increasing access to care and advancing equity. And I would highly recommend checking out Lacey's episode. We've also spoken with Dr. Newman, Dr. David Newman, who is the Chief Medical Officer of Sanford Health. And he had some really interesting stories about some of the satellite clinics that Mark had mentioned. And we've also spoken with Dr. Bradley Anderson and Jared Rose from OSU, who will be speaking later this morning. So, you guys are already here listening to these excellent speakers. If you do want to sign up or listen to the podcast, I am the presenter, so it does mean you have to listen to me talk for longer. I don't know if that's really a good thing, but the other speakers who are not me are fantastic, so I highly recommend it. You can pop yes, send me the link in the poll here, or you can search for Access Amplified anywhere that you get your podcasts. And as Lacey mentioned, don't forget to leave questions. We've got some really interesting ones coming in, and I'm looking forward to diving into those as part of the roundtable. I'm now really excited to introduce our next speakers, Pam Hilton and Taylor Carlin, who work on school-based services at Tri-Area Community Health, who are providing comprehensive care for patients across Virginia. Pam and Taylor are going to be sharing their approach to bringing care into the communities in a slightly different way than some of our other speakers today. Some of you already know that we hosted our School Health Virtual Summit in January, but we wanted to invite Pam and Taylor to speak about their school-based program here because it's really an excellent way of bringing care to patients in rural areas, leveraging facilities that are already existing, already have community-centered activities, and already have connectivity set up in most cases as well. Thank you so much for joining us today, Pam and Taylor.
Thank you, Joanna. Hope everybody's still awake and not starving to death behind your desk. So please go grab a snack if you haven't gotten around to lunch yet. Again, thank you for having us. I'm Pam Hilton with Tri-Area Community Health. We're a federally qualified healthcare center in Southwest Virginia. We have several community clinics, but recently in the past couple of years, we've started adding school-based clinics to our range of services. So we have 3 of those already established and 2 that will be opening at the coming school year. And what we have found as we have gone on this new adventure is that relationships are really the heart of making those connections with schools. So that's what I want to talk about today, just how trust and community relationships make all the difference in a successful telehealth program. Next slide. All right, so this is a very zoomed in map of our region. I noticed a lot of attendees today are from other areas of the country. This is the southwest corner of Virginia, where we border West Virginia, Kentucky, Tennessee, and North Carolina. And we really are in the holler, is what my mom calls it. And so they're the nearest, what we consider to be cities, are Roanoke, Blacksburg, Bristol, Johnson City, Tennessee, Winston-Salem, North Carolina. Those are the big cities to us. And meanwhile, we're sort of isolated here. And so if you're familiar with rural healthcare, you already know long drives, curvy gravel roads that don't get scraped when the snow comes down, the cost of gas, having reliable transportation, all of these things are barriers to care. Additionally, with our population density being so sparse, it's hard to justify having a provider in an area where you might not have enough patients to be sustainable. It's also hard to attract providers to the rural areas because we have less, in some people's eyes, less to offer as far as recreational, cultural, that type of thing. So sometimes it's hard to get people to live here. I don't know why, because I think it's beautiful. I was born and raised here. I'll live here forever. So I think it's a wonderful place to work, but it does create some limitations with filling positions. And then finally, we are in these isolated areas where you'll often find people are not accepting of new things as much, maybe skeptical of outsiders, and prefer more well-established brands and businesses over some new idea. So with those challenges, this is what makes school-based a really good entryway to rural areas. Next slide. And so why schools? For one thing, the buildings are often really important to the residents. They may have historic significance as a building that was once used for something else that has a positive memory for long-term residents. They're also used for multi-purpose activities, like on election day. Some of our schools are closed because they're used for polling sites. When it's a danger of power outage, the schools may offer to be used as a warming center or an emergency shelter. And the other thing about school buildings is that they're usually centrally located in rural areas. They've been there forever. Everybody knows where it is. So, so just the fact of being in a school building to do telehealth makes it automatically a little bit more comfortable, and families are more trusting because of the place where services are going to be provided. All right, so key staff. If you're thinking about starting a school-based program, or if you already have one, we have found certain roles to be priceless in our organization. The first one is our virtual care coordinator, which is Taylor Carlin. She's on the call with me, and so just to introduce her a bit, she is our central point of contact for any new patient who is registering, getting started with Tri-Area, or if they're already with Tri-Area and they're going to use our school-based services. And we have found that having this central point of contact is really helpful, that people get comfortable with the same person, they know who to call, and meanwhile, she's becoming an expert in who to talk to at each school, the school nurses, school counselors, what time of day they want their appointments, and so forth. And so having that expert on the staff has made a huge difference for us. Taylor, can you talk for a minute about how you get this job done?
Yeah. So setting up for our school-based clinic is very easy. The parents or guardians can sign their child up online through our tri-area website or their county school's website. If they don't have internet access, the school can send a paper registration home with the student. Once I get those registration forms back, I go ahead and create the student's chart in our electronic system, and then we set them up for their appointments of whatever they need, whether it's medical care or counseling. For our elementary and our middle school students who aren't seen in person, I set up virtual appointments with the school nurse or the school counselor. And just keeping the school aware of those appointments really keeps and helps everything run smoothly. If the student is already one of our patients with tri-area, and all the parent has to do is sign a consent to treat form so we can see them without the child, or see the child without the parent being there.
Thank you, Taylor. So as you can see, there's a lot of moving parts, and having this care coordinator there to reassure people that we've got you covered and we're going to get you connected is just such a pleasant experience for that first impression that's so important. Another position that we have that's unique, as far as we know, in Virginia. None of the other school-based programs have this role. It's called Behavioral Health Outreach Educator. And so this person is our boots on the ground individual who makes that human connection in the schools to ensure that they remember that we are a resource for them, that their equipment is up and running at the site. And they can also offer support to the school in the form of staff trainings on a topic of their choice related to behavioral health concerns, which are usually pretty high on the priority list for schools to be able to manage that issue. They can do parent workshops on similar topics, and they also attend community events and just to show our support for stuff that families are already doing and trying to be there where they already are. And finally, the community liaison, that person is not an employee of our organization, but they work for the school. So in this particular county, they have designated a staff person to handle all of the school community partnerships, and that gives us a central point of contact. Not all of our counties have this person, and we have found that getting things scheduled, arranged, changed, getting involved is much easier when we have that point of contact at the school. So whether you're on the healthcare provider end or you're at the school, in the school system, it's just really good to know, who am I calling? I mean, that I don't know, maybe in cities you get used to talking to just whoever answers the phone, but around here we sort of like to know who it is, what's their name, and ask for people by name. And so that's been really important to our success. Common concerns that skeptical users might have, or parents who are new to this. First of all, who is it? Who's doing this? I think sometimes when people hear telehealth, they're a little bit afraid because I don't know, it could be somebody on the other side of the country, and that's just a little bit unsettling for some. So we always introduce our medical providers and our nurses at the faculty convocations at the beginning of the school year. They'll come up on stage and sort of wave so we can see, at least the staff can see who's providing the care. We also put their picture and bio on the website so they can look up information before deciding they want to sign up for this. And we distribute materials that shows our treatment team and talks about the provider's expertise. We like to be on site during open houses at the schools so that parents can step in and see the equipment and see the space that Tri-Area uses at the school to be more comfortable with that. The how, I have a photo of our lovely Taylor Carlin, who just spoke to you a minute ago. And that's really what our how is call Taylor and Taylor will let you know. But she makes things so simple that once one person has figured it out, a lot of times word of mouth is really what spreads and gets people calling and asking about our services. And Taylor makes it so simple that they're reassured by that. The what is basically just making sure you're staying in contact with the community to tell them what's going on, what you're doing. This is just an image of a flyer that we sent home that has our QR code for parents to just go ahead and register even if they don't need an appointment, get pre-registered. But we also regularly update our social media and the school social media about if anything's changed about our hours or if we're offering something seasonal like flu shots. Okay, 5 ways to build trust in telehealth. First of all, you have to really bond with your school nurses and school counselors in the schools where you work. Like I said before, that first impression makes a big difference. So I'm probably always going to bring cookies or some type of snacks with me whenever I show up at a school, knowing that's something that school employees typically get excited about. And so we try to make that bond first with school personnel so that they trust us. Secondly, we do a group training at the beginning of the school year with the Title Care device for all school nurses to see a mock appointment being done with the device and to have a Title rep on the screen to answer any questions. And then our IT folks go to the individual schools and meet with the school nurses in their environment to show them the device again and make sure they don't have any questions or trouble with the equipment itself. Third, meet families, and that just means being where they are. This is a photo of Robin Graham, our behavioral health educator at the local splash pad. So in the summer, she set up a table there with some information about our program and just hung out with the kids and families. For community champions, this is about networking, getting to know other service providers in the area that do similar things and figuring out how we can partner to maximize what we're all trying to offer, which is help and care for kids. In this photo, this is a pet therapy dog from Pet Partners, which is a local agency that provides pet therapy, and our behavioral health educator arranged for the pet therapy dog to visit the school on occasion. And so that has supplemented what the school would have ordinarily been able to provide. And again, it just continues to show from Tri-Area, we care about you. We want you to have the best, and we want you to have new and different experiences that are supported. And last, just spending time together is so important to keep conversations going. In this photo, it's a team of providers from Tri-Area who volunteered their time on a Saturday to participate in a free athletic physicals event. And by doing that, you get the conversation started about sports and athletics and other topics that come up, and that patient is more likely to return to the clinic and use us for their healthcare moving forward because they've got that conversation started. Now the provider knows what sport they're in. They can ask them how the season's going, and it's just a way to build that bond. All right, for a case example, this is about meeting people where they are. So we have, in one of our school systems, it's about 30% Hispanic, and many have parents who are totally Spanish speaking. So in this particular example, a 5-year-old came to school very sick. He had already been to urgent care with his mom, but he wasn't getting better. And so the school nurse and their translator explained the telehealth system and how they could have their medical appointment at school and see the doctor. And the mother agreed, did the forms online, had their telehealth visit. She followed the advice that was given, and then the child came into the clinic and was seen in person later with the use of our translator, which we use the Boost Lingo service for that. And the child ended up recovering well. The mother was extremely grateful, and now we have a new connection. And again, it's it's that word of mouth, because if this mother returns to her community or neighborhood and says, like, it doesn't matter if you don't speak English, they're still going to take care of you. I think that's good information to have out there, that we really want to just meet you wherever you are. Another example that I have is related to strategy. All right, and so this Yossi with Title Care showed me how to use the administrative dashboard to run reports, and I just love numbers, so that got me real excited. And I was able to look at utilization. And so in doing that, I can make comparisons. Where are people really taking advantage of this, and where are people maybe avoiding it, or we haven't promoted it well? And so, for example, with this data here, I noticed that the middle school had lower utilization, which doesn't make sense because the clinic is at the high school. So if we're doing a lot of telehealth, it's most likely to the middle and elementary schools. So that just kind of makes me stop and reflect. What would be the reason for middle school not having as much usage? And that gives me an opportunity to reach out to them, attend a faculty meeting and talk about what we have to offer, meet again with school nurses or counselors, and just find out if there's any barrier, something we may have overlooked, or a breakdown in the system somewhere. So I think that was all that we had for today. Just basically emphasizing that it's not providing the best device in the world that's going to make the difference. It's making that connection with your audience or your consumer base, whatever you want to call it, with your community, and so that they know that you're there to take care of them, because that's our mission, that's our passion. So our contact information is there. If anybody would like to follow up, we'd be glad to have a Zoom call or Teams meeting in the future just to talk about how it's worked for us.
Amazing. Thank you so much, Pam, and thank you, Taylor, as well. I noticed that you both have a couple of messages waiting for you in the chat already. Pam, I really liked how you said the how is literally Taylor. I'm not sure, Taylor, I don't know if you have a cloning machine or a way that we can kind of make you go around everyone. But, I think even if we can't make that happen, this was such a great overview of how you've built the program and how you've built those relationships that really underpin how this works and how this works smoothly, especially in so many rural communities where everyone knows everyone else, and where leaning on those relationships and on those trusted sites and trusted people makes such a difference. So thank you both so much for sharing that with us today. If you are interested in watching the School Health Virtual Summit that I mentioned earlier, we can share that with you to your inbox. So you have a poll on the screen. Just let us know if you're interested in receiving that, and we can send it over to you. And again, please do feel free to pop some questions into the Q&A for our speakers when we hit our round table section later. So I'm now excited to introduce our next speakers and our last speakers for the day. We have joining us now Dr. Bradley Anderson and Jared Droz, who are the Medical Director and the Director of Virtual Care from OSU. Thank you both for joining us today. I'm really excited for your presentation. Jared and Dr. Anderson are going to give us a great overview of what they're doing at OSU, which is an incredibly broad and thoughtful program, as well as a look at some of the innovative elements that they have coming up in the future. Thank you both so much.
Yeah, awesome. Joe, thank you. Appreciate the invite. Always great to connect with you guys and everybody else on the call. Glad we can kind of round out the Rural Health Summit. Very excited to give you guys a rundown of everything we're doing OSU Medicine virtual care wise, and also go through kind of the next iteration of what we're thinking of, piloting through the state of Oklahoma, kind of leading the charge for that. So I get the opportunity to create, innovate, and be part of this great group of operational leaders, IT, physician, clinician leaders to build and create these programs. And so we're in probably around 40 sites around the state of Oklahoma, and we'll go through kind of our map here in a little bit. But I get the privilege to kind of work with Dr. Anderson and all of his team. So my title is Director of Virtual Care for OSU. And so over the last 3 years, we've built a really great program, all with the means of creating access and giving that opportunity to rural Oklahomans. So Dr. Anderson, if you want to introduce yourself real quick, we'll continue rolling.
Sure, absolutely. So Dr. Bradley Anderson, I'm a internal medicine physician, the medical director of virtual care in our health access network here at Oklahoma State University. Very excited to talk to you guys again today. Jared and I always enjoy getting to speak on what we do because we're just so excited to be able to provide a little bit of increased access to care across Oklahoma and give some ideas to other locations. We were just actually talking through some of the presentations. Just it's interesting to hear from other people doing very similar things, also having similar problems that we have. So these are always great to be able to kind of bounce ideas off of, hear other people's ideas, and just get some ideas for us in the future. So appreciate everyone speaking before us and our ability to be able to talk to you today, and looking forward to the questions and answers afterwards. Go ahead, Jared.
Yeah, sounds good. Yeah, so as you can kind of see, the map of Oklahoma here's our kind of healthcare professional shortage area. And so for us, obviously, this is kind of a call to action, right? This is where virtual care becomes kind of the strategy that's necessary in what we do. And so a little bit about OSU Medicine, right? We have our medical school here at the Tulsa campus. So Tulsa is in that northeastern corridor. If you look at that kind of light blue area there in that corner, that's where we're at. And so we've got our teaching facility hospital that's next to us, actually across the river from us. It's OSU Medical Center. And so we are part of that healthcare delivery arm that makes up kind of OSU Medicine. And so as you can see, obviously, lots of opportunity, right? And so our focus and mission is obviously to train physicians as well as other clinicians. We have a PA program as well. And so we are continuing to try to place those folks in rural Oklahoma as well. And so we can also do that virtually. So next slide, please. Yeah, and so here's just a little bit of map of Oklahoma, again, critical access hospitals. Actually, and this is a little bit older map, but we actually now have 4, maybe 5 coming up, but 4 rural emergency hospitals. I think maybe it could have been Alexis with ATA that talked a little bit about that model before us. But again, a new model that's coming up. I think we may have maybe 1 more coming up in the state of Oklahoma soon. So it just gives you an idea of everything that you could see geography-wise for our hospitals. So, yeah. So how do we connect those dots, right? How are we part of that? For us, it's again, you look at all the shortage areas. How can we bring that high-quality healthcare access to our rural Oklahomans, right? And so how we can do that is through virtual care. We partner with local hospitals, with local clinics. And for us, it's how can we bring what we do today to those local communities. So we bridge that gap. And again, for us, virtual care isn't just virtual care, it's healthcare, right? And so it's an important part of that. So next slide, please. Again, so this is our care, kind of all of our tiles here, what we do in terms of care. It's consults, digital health, mobile health, telemedicine, e-medicine, RPM, you name it, any and everything that falls underneath that care umbrella. So next slide, please. Message from our president, Dr. Johnny Stevens. And so he kind of sets the course of obviously the intensity that we put behind that. As you can see his comments there, we want to be that innovative leader in telehealth and virtual care for the state of Oklahoma. What you'll find out about OSU Medicine is if there's a rural problem to solve, you're going to find OSU in the mix of that. And how can we be a solution to our neighbors in those counties? So next slide, please. Here's our map. This is, again, in around 40 sites, around the state of Oklahoma. We're actually going to add a couple more here to this. But as you can see, kind of concentration-wise, when you look at all of our healthcare disparities, southeastern Oklahoma and even out west are probably the top 2 in terms of areas that need a lot of focus, intention, and more service access there. And so we've peppered around quite a few the state of Oklahoma. But again, for us, it's a statewide leadership focus. And so we are aimed at doing that. So next slide, please. And again, when we kind of level set with this, our goals here, how do we increase access, allow patients to stay local, right? Increase specialty care services, support our communities. We're going to talk about some of the ways that we do that with our community health worker and how we can kind of, again, make positive influence on those social drivers of health. And then how can we use low barrier technology, and how do we, improve access to that? And so we've got some great solutions. We'll talk through that. So next slide, please. And so how we do that, here's all of our tiles of everything that we do today in service offering. And kind of the title of our chat today is kind of looking at how do we go into that next phase, which is going to be some virtual OB services and clinic. And so we're going to need to add another tile here. But as you can see, from everything to hospitalists, cardiology, psychiatric addiction consults, school-based. I know we just listened to some really great content about school-based and some of the uniqueness of that care model. We've got some mobile clinics. We do primary care. We have a tribal affiliation with our Choctaw Nation tribal health folks, and we have a clinic that's in a remote part of southeastern Oklahoma. And then our next is kind of our provider training program, and we'll talk a little bit through that. So next slide. So how we kind of connect all that, we're a little bit of a dual shop. We are an Epic enterprise, but also that sits a little bit outside of our Epic environment and allows us to connect with so many hospitals is Andor Health. And so we're actually able to integrate our Title Care technology into Andor. And so it allows us to do everything kind of digital front door wise, right? We've got, e-consents, e-visits, all of that. And we're able to communicate effectively kind of back and forth through Andor. That's kind of how we get that connected. So next slide, please. And then of course, Title Care. We've seen and experienced some interesting technology to really massive, large, clunky carts, and to now we've got something that's really easy to use and that's handheld with an iPad. Probably like others on our call, they know kind of the simplicity of use of Title Care. It's a great tool to use and easy to train others, even non-healthcare professionals. We always say if Dr. Anderson can train me, anybody could do it. So next slide. So now kind of, again, our current initiatives that we have, this is a picture of some of our team here. So Robin, who you see, I heard somebody talk about their virtual care coordinator. Robin's kind of that same person for us. She is our air traffic controller. Everything kind of funnels through Robin, and she kind of dictates and drives where those phone calls and support needs to go. And so you definitely need one of those. You need a Robin. And so next is Mike. He's our executive director, great supporter of what we do today, kind of leading everything that we do on our strategy side. And obviously myself, Dr. Anderson. This is one of our critical access hospitals here in Cleveland. We provide 24/7 support for them. And we're seeing some fantastic numbers and outcomes with that group. We've been connected with them probably the last year and a half. And just an absolutely wonderful story we'll go into a little bit about. Next slide, please. Some other services, obviously, we talked about a little bit here. One thing I'll call out too on this is our school-based we're going to talk a little bit about, but school-based is really a little bit of a niche for us, and we really have a lot of passion that sits behind school-based and how we can drive that for the state of Oklahoma. One of kind of the first of many to be in a rural place. And a lot of times, and you all know probably on this call, access is critical, and we have trained even folks who are non-clinical to work, the Title Care device, be able to provide that support even when there's not a nurse on site. So we've done a few different models, and we've done it a few different ways. So excited to share that. And then our population health pilot, which we're not going to talk a whole lot about today, but it's something that's very exciting that hopefully we can share here in the near future as we continue to go kind of down that path with some really innovative technology. So next slide, please. So our Choctaw Nation Hybrid Clinic, we're very proud of that, very proud of the relationship and partnership we have. This is in the Antlers, Oklahoma. Again, you can see the population, 25,000 or maybe even less now. Chief Batten is in the middle there with our president, Johnny Stevens. Dr. Hill to his left is their chief medical officer. What was really unique about this visit, this was our kickoff visit here in Antlers, and it's a small clinic, 2 exam rooms, small lab, but it gets everything consolidated to a place where you provide that access in kind of a smaller footprint. And what's kind of neat to call out, Jen is our PA, and you could see her kind of on the cart there. She was actually virtual that day, so it kind of lends to, of course, virtual care and what we do. So really great picture with Jen on the device. So, and this one is open to community members too, not just tribal. And so it really speaks to their work and, you know, connecting with not just tribal members, but also community members in and around that county. So next slide, please. And so our intention behind some of this is how do we reimagine what Main Street looks like? So for us, we can provide some economic support for them. And one of the things that we have, it's in a kind of a small strip center. It's got about 5 different other businesses or locations. So we placed the clinic there, and 3 other spots have opened up. I think one's a daycare, one's a behavioral health clinic. And so when you start to, you know, make that investment into some of those smaller rural health kind of initiatives, you definitely look at Main Street as an opportunity. It's an open space that you can put kind of a smaller footprint, and hopefully that attracts, again, local jobs, local support, local revenue staying there in those communities. So it's been a great partnership. So next slide, please. This is our connection with our OSU Extension Office. We provide some free clinics to that group. It's a great connection. Our Extension Office serves a lot of our rural communities and counties. They do a lot of soil testing, from agriculture education to nutritional supplementation education. It's a great program with our Extension Office. And we have 2 sites that we take our mobile van to. You can go to the next slide. You can kind of see the inside of that. That's a little bit of our program. So we can do any and everything in that van there. We can do blood work to, you know, screenings, you name it. So it's a great way to provide and bring access. So next slide, please. Kind of go through these a little bit quicker so we can get to kind of the meat of the program. Next thing we're working on really is to talk about our Telehealth training program. I think Sanford Health talked a little bit about their ER program. We're looking to train and attract our APPs and nurse practitioners that live within other rural hospitals that need that additional education and support. We don't provide that within our SIM center. It's kind of a phase 1 approach. Phase 2 goes to virtual consult with our board certified emergency medicine group. So excited to do that. And then we actually just started our transitional care management program with our hospital OSU Medical Center. So that's a great next step. So next slide, please. A little bit about, obviously, our TCM program. We're getting ready to launch that, so excited to give some outcomes here. Probably the next 6 months or so are what we're seeing and the value of that, of what we're doing. So probably some others have TCM. We're doing that in a virtual capacity where we're doing those virtual visit-wise. So it should be exciting to see how that pans out. Next slide. Our community health worker, again, for those of you who don't have one, please invest in that. If I could have 5 more, 10 more, I probably would. They are extremely vital and important. Vanessa is our community health worker. She sits actually at every one of our extension offices, and she greets and connects with everyone that walks up. So it's a wonderful opportunity to meet folks in the community where they're at and be able to help provide assistance when needed. So next slide, please. All right, school sites. This is some of our team here. You can see GNRPA and some other folks on the team here. This is one of the things. We're in 14 school districts across the state, and so we cover around 20,000 patient lives today. And so it's a wonderful program that we have seen a lot of success on. Next slide, please, and we'll go into a little bit of that. As you can see, there's the rest. There's Phyllis. She's our nurse practitioner. She leads our school-based program and sees all of our kiddos. Vanessa's on the left is our community health worker there again. Vanessa kind of spans across all of our service lines and programs. One of the great things that we're seeing in terms of our outcomes is kind of on average savings, approximately around $200 per family when you think of gas costs, time taken off work. Sometimes, they're 25, 30 minutes from just driving to kind of that next urgent care location. So for us, it's a great opportunity and testament to the work that we're doing. So next slide, please. And then this is kind of our telehealth adoption. When we see these things work really well, you see that hospital margin kind of upticks into that positive area. And we're seeing, it's a great article, which is linked in the referenced slide on this presentation that talks about those adopting telehealth. Wonderful, wonderful by the American College of Healthcare Executives. So encourage you all to go read that. What we're seeing in terms of us, 80% reduction, and we're able to keep those patients there local in their community when they get us engaged. And as you can see, kind of the average additional revenue per patient that we're able to provide for those critical access hospitals. A lot of swing bed that we see, and so that number is reflective of that. So next slide, please. And then here's some of the other stats that we're able to obviously help support. Reduction in EMS transfers that opens up counties to make sure that sometimes you just have one ambulance in a county, and so they're able to have that resource be needed for those who really need that support and help immediately. Reduce that, and then reduce again even the recruitment cost to have internal medicine physicians at some of our hospitals is very key and critical. So next slide. Again, our congressional advocacy and what we do to talk about everything that we have going on. Kevin Hearn, who is now, it looks like running for a Senate seat. So we had the opportunity to host him and his team. So anytime you have the opportunity to advocate for what you're doing, especially with all of your legislators in your state, please take that opportunity. He's been a wonderful supporter of ours and everything that we're doing to reach rural Oklahomans. So next slide. All right. Here for our talk, so expanding OSU virtual care into maternal health. And so I'll preface this with a little bit. Obviously, we have not launched this program today. It's not live. We are in kind of build phase with this program, setting up protocols, setting up our sites, working with our OB-GYN chair, who is excited to kind of participate in this and really see this come to fruition. So next slide, please. To kind of level set and give you all kind of where we're at in terms of the Oklahoma maternal care landscape. If you look at that, 51% of our counties are maternity care deserts, right? And so that means there's no hospital that delivers, there's no OB, even midwives reported to deliver in those counties. And so when you look at that number, that's a huge call to action. It's something that we, in terms of our strategy over the last probably 3 to 5 years, have really wanted to build and be part of something there. And so for us, we're finally getting the opportunity to be able to do that. So we're very excited to be part of that. I don't know, Dr. Anderson, if you want to add any comments to that.
Yeah, I mean, I just think that, maternity care is obviously, a big hot topic right now. It's a hot topic here in Oklahoma, and just the maternity deserts that are aware and, the overall care with mothers in that situation, I think it's a very important thing. So we're excited to just kind of get this started across Oklahoma and hopefully just, again, increase access to care, which always seems to be my theme when I speak, but really increasing access to care to these areas that really need this type of care.
Yeah. Next slide, please. And so now let's go a little bit into kind of, again, our program. And again, we're building this. So obviously there's going to be things that you see on here that we may have updated, right, in the next time that we get to discuss about this. But for us, it's how do we bring our OB physicians to rural communities without having that travel component. And obviously there's a lot of things on the back end that we're working through of how to set that up and make sure that we've got a great blend and mix of virtual care along with hands-on care. And I think that's really important as we work closely with all of our sites. And we're starting in a place where our hospitals, our health system that we are partnering with are probably 30 to 45 minutes within a facility that, delivers. And so that gives us an opportunity to kind of pilot this program, walk through kind of all the ups and downs and kind of speed bumps that we are going to run across. But very excited to do that. And so within this program, you'll see as we can kind of continue talking through this, but not only are we providing that OB care, we're also providing our community health worker, perinatal navigator, and how can they, and our care management group that we have here. And so how can we infiltrate all of that and really provide kind of that wraparound care so they aren't feeling left like I'm just talking to my physician on the screen, right? I've got a relationship with OSU and I've got a relationship with my local hospital and healthcare. So I've got lots of people looking out for me in terms of how we can, safely deliver. So right now, again, we're in that kind of pathway building. As we see this, part of that other piece to this program is going to be kind of our maternal behavioral health collaborative care workflow. As you can see, we'll be able to do appropriate screenings. And depending on those screenings there, we'll be able to give kind of warm handoffs either to our community health worker, even do virtual visits for those who might need support for psychiatry or any substance use disorder that we may run across. And so we're very much excited to add that as kind of an add-on to the program with that. So areas of impact, right, that we're trying to measure and hopefully can be, come back to you guys in 6, 7, 8 months and have something at least to talk about. But increasing access, of course, or utilization. What do no-show rates look like? Are people adapting to a virtual OB model? Are we keeping transfers, higher level of care down? Are we able to help them stay local, which saves them time, gas, all the resources that might need to get to, a larger or another, town for care? And then all of our social drivers of health and those behavioral health outcomes. And then again, overall experience, not just from the patient side, but also from the physician and clinician side of this. So we're very much excited to that. So next slide, please. And so kind of our program and model here, right? So we're going to have at least probably 6 telehealth sites, our spoke sites across the state of Oklahoma. We're going to support everything from, prenatal to postpartum care, anything kind of women health services. We're also in discussion with some other OB-GYN related care delivery systems that we can bring on top of this and layer in with it, not just OB. So we're thinking through different ways to provide more in terms of total women's health services. So that's a great thing that we're working on. And then, kind of how do we partner with, again, our local support to provide the in-person clinical needs, ultrasound as well at those local sites. So how can we bring revenue that way to them as well? So the next thing I'll probably say in terms of what we're looking at for this is, how can we expand this to a place that really reaches those, again, that are at a place that probably wouldn't get care coverage, right? I mean, when we think of the areas that we want to look at, southeastern Oklahoma being one of those, we may go into a place where sometimes we're seeing patients that probably waited till, mid or late trimesters just to get kind of that first initial visit. So that's what we're trying to infiltrate and attract and be able to make a difference in that way. To really see some good maternal health outcomes for the state of Oklahoma. Last thing I'll mention to this too is kind of just our structure here. Again, I mentioned we're a little bit of a hybrid with Epic and Andor Health, but we'll be using Epic for this adventure that we're going to go on. So excited for all of those features too. So Dr. Anderson, I'm going to pause and let you kind of talk anything else in terms of kind of virtual OB.
Yeah, you did a great job reviewing kind of everything we're doing. Again, just kind of building this program a little bit, but I do feel like, kind of a hybrid model with connection back to, local providers is going to be key. Just making sure that we can increase access overall to OB physicians, and then hopefully, as well to maternal fetal medicine and improve overall, care when it comes to, especially some of those more complicated situations that makes it more difficult for some of these rural patients to really get into the larger facilities that have these kind of higher level providers. For example, maternal fetal medicine, it's very, very hard to come by in Oklahoma, really Tulsa and Oklahoma City being the only locations that have that specific specialty. But we do have, quite a large population who really need those kind of higher level specialty care providers. So just having the opportunity even to really be able to increase access to those specialists is a huge thing to have here in Oklahoma. But overall, did a great job talking about the program and everything.
The other thing I'll probably mention too, as we're thinking through this, is our original vision is kind of this 3-legged stool, if you will. You've got OB, behavioral health, psychiatry, and also nutrition to that, right? So a lot of this being virtual, how can we bring either dietitians into this mix? How can we be and play a part in that as well. A lot of conversation around food as medicine as well. So a lot of things we're starting to build on this end that I think are really shaping up to be a well-rounded program. And we're very, very much excited for that. So, yeah, I think that might be at least the end of our slides. So Joe, I'm gonna turn it back to you. Questions? Yeah.
Thank you so much. I think that is, I'm first of all, I book you in now for next year so that you can tell us what happened next. But I think the breadth and the depth of what you're building out within that program, right? Not just kind of looking at how do we solve those surface level challenges, but also looking at, you mentioned nutrition, there's a whole bunch of different kind of levels of care there, which we women need when we're pregnant, and especially when it's hard for us to travel. I actually, I felt very strongly when I was pregnant that I should be allowed to drive in the hard shoulder. I don't know if that's what you call it in America. Is that what you call it? Like the safety lane at the side of the road?
Oh,
because if I need to pee, get out of my way,
Right.
But I was lucky.
Hit the fast lane and go. Yeah, hit the gas. Right.
But I was lucky that I had care close by. I live in a fairly rural environment, but I was able to get my obstetrics checkups and everything that I needed locally. And I also had a very simple pregnancy. So lots of things to be grateful for, but people should definitely get out of our way when we're pregnant. We need to pee on the road. But the idea of building something like this that does kind of solve those challenges, especially in rural areas. Again, just you're committed to coming back next year and
yeah, we'd love to. Yeah,
what you're doing. Great, thank you so much. So I'm going to invite everyone back for the roundtable in just a second. Before I do that, I wanted to just kind of let everyone on the call know, for anyone who's interested, we are going to be opening applications for Tyto Care evaluation kits. And this includes a Tyto Care kit that gets sent to you so you can see how it works and how it could potentially integrate into your virtual care programs. The kit that you get is actually one that you can use at home with your families, but it will give you an understanding of the solution and how it works in clinics and schools and rural areas and rural clinics as well. We're going to pop that link in the chat box now. And if you are interested, you can head over there and fill in the link to apply for one of those kits. So now I'm going to invite all of our speakers back for our roundtable. Thank you all so much for all of your presentations. Like I said, have at least, I don't want to quantify it with a number, but I have many, many questions for you all. But let's start with some of those audience questions, because that's what everyone's here for, and not to listen to me. So let's start with a very broad question, because this is one that we get a lot, and I'm guessing that you guys do as well, which is, how are you reaching patients who struggle with broadband access in rural areas? Does anyone want to, Lacey, I know that we've discussed this before, you've got the best broadband of all of us, but does anyone, Lacey, do you want to start, and then we can kind of take it away?
Yeah, that's because we're so rural in South Dakota. Internet accessibility is a barrier for many of our patients. That's why we offer the dynamic broad of access. They can either do the telehome ones or come into the clinic where we can get them connected using our network accessibility. We found in some of our communities, there's folks that don't even have fiber connection. Some of them are still using DSL, some of the older satellite swarm internet, where luckily we've been able to partner with different telco agencies, different grant programs, funding opportunities to help up and amp our network access, I guess, in our clinics too, to provide that broadband connectivity for our providers as well. So if the folks aren't able to connect from home, we're usually able to get them into the clinic and provide a good solid connection that way. So we've been fortunate enough to work with the different entities in the state of South Dakota to help us expand that and improve that in some of our rural areas. So
thanks, Lacey. Would someone else like to jump in?
Yeah, I'll mention, one thing, and not everybody may not be able to do this, but we were very fortunate to have 2 mobile units. One actually primary care, second we're gearing up for cardiology. And so everything that we can do, we run off a hotspot. So if I can get a van or drive it to a location, I can run what we need to care for somebody off a hotspot. Even in kind of remote parts of Oklahoma, for example, we've got a community that doesn't have running water, doesn't have great access. And so, if I can get the van there, I can gain access through a hotspot to do a video visit, to do whatever else we need. So that's just one way for us to do that. I don't know.
Yeah, I think that's something that, we kind of have mentioned a few times, those kind of satellite clinics. And that's definitely, and even the schools is a good example of that. It's a good way to kind of bypass those individual housing connectivity issues, because by creating this kind of central hub within the communities, that becomes the health system problem. And as health systems, we tend to have more leverage than, Mrs. Smith, who's kind of trying to connect to her internet. And then that way those patients can drive those 20 minutes or whatever it is, as opposed to kind of having to go all the way in. Mark, did you have something that you wanted to add?
I was just going to echo what they already said. And yeah, put in a plug, satellite clinic. It's low cost and you get them that network access that they might not have at home. So.
Okay. I'm going to take another question, because there's something here that, I feel quite strongly about, but what are the panelists' thoughts on async virtual care, if it's chat only, no audio or video? Will it evolve to include diagnosis and treatment, such as prescriptions for acute infections? And specifically also asking Alexis what your the ATA, CMS, and HHS positions are as well. Is that something you'd feel comfortable taking this away with?
Yeah, sure. Definitely a hot topic right now, I feel like. So I have multiple answers to this, I feel like, and anyone else feel free to chime in. You all are doing on the ground work, but I feel like for asynchronous care, it's already being done through a lot of different companies, through the Roe and the Hims of the world. And they're actually prescribing and diagnosing. Now, when a patient goes online and they do this really intense intake form, the provider is still reviewing it on the other end, essentially. So it's not like the provider is left out of the loop in total. And so as far as how CMS, HHS, how they view that, I think CMS is reimbursing it through the e-visits, as I think one of y'all were talking about in a way. And then as far as legislatively on the Hill, I feel like asynchronous is only really reimbursed for Hawaii and Arizona. Hawaii and Alaska. So it's very specific. But I think that they're open to it. We have seen a lot of skepticism around the direct consumer models, especially when it comes to FDA, FTC, how they're advertising for certain drugs can be alarming. And so they've been under some scrutiny, to be honest. So I don't know. I think people just need to learn more about them, right? I think once the provider is actually taken out of the loop, we're looking more at AI. And I think we have seen that now. And Utah is a perfect example where they have now allowed some sort of AI bot to prescribe to patients. And it's one of the first sandboxes actually that has been put into place. So it'll be interesting to see how that plays out. But it's a very interesting topic in general. And hopefully that answers it well. Anyone else feel free to chime in too if I missed anything.
Yes, we do quite a few e-visits today. We actually switched to a flat fee upfront model in 2024 after some of the telehealth capabilities went away. in terms of being able to charge a level of service for any individual encounter for that service. So we went to flat fee in 2024. And so for the past 2 years, we've seen steady, if not increased usage despite that change. So.
Thanks, Mark. Thanks, Alexis. Does anyone else want to chime in on that one? Okay, great. So we have a question here about school telehealth, and I want to ask Pam and Taylor, I want to start with you. But I know, obviously, Jared, Dr. Anderson, you may also have thoughts on this, especially because I'm pretty sure the answer is going to be that it's going to vary from state to state. But how does reimbursement work for school telehealth? Are all patients eligible for coverage as FQHC or Medicaid, or are patients with private pay or kids with private pay covered?
The Tri-Area accepts every insurance you can think of, including Medicaid and Medicare. But we also provide a sliding scale based on income for the uninsured. And fortunately, in Virginia, there have been several grant opportunities recently to expand telehealth in schools in particular. So we did receive, or the school systems that we serve did receive that grant. So the way that we have set that up is the mental health services for those counties are delivered at no cost, thanks to the grant. And then the second question I saw, I can go ahead and answer that. We go with what the school wants to do in terms of who is authorized to use their clinic. Of course, schools have to be really particular about security issues because, unfortunately, there have been violent incidents that we all know about in schools. So it depends their comfort level with letting outsiders come into the building, and if they have protocols in place. We're always open to see whoever wants to use our clinics, because that's our goal, is increased access. But it may be that the school isn't comfortable with that. So as of now, most of our clinics only serve students and staff. But we do have one clinic that has allowed the local sheriff's department and town employees also use the clinic. Of course, those people would all be background checked, and that kind of thing is why I think that school system was comfortable with that. But we generally only operate on school hours, and that includes weather. So if you're in a rural area and you have crazy weather, schools get closed a lot, that's a bit of a challenge. We do try to continue offering services by telehealth for kids at home that have access to the internet and can still be seen that way.
Thanks so much, Pam. Jared, do you want to?
Yeah, to add to that, and Pam, I think you guys were talking earlier about there's no snow plows in those back roads. Definitely not here in Oklahoma either. We experienced that same thing. I think it's really neat just to call out your program if you're having community members come in. That's wonderful. We particularly are just inside schools, only school. Anybody that lives in that district can access care. For us, we're fortunate too. We actually had a philanthropic donor support the program for a couple of years, but in terms of the state of Oklahoma, you can bill as well for commercial for us. There's another program that's down in southeastern Oklahoma that does kind of the same thing with a few schools as well. And so, yes, that option is available. The state of Oklahoma is looking at kind of flipping that, I believe. There's a few Senate bills going around now, maybe to allow school systems to receive that funding and then kind of repurpose that out. So that will be interesting to see if that goes through or not. I don't know. The other thing to mention, obviously, is rural health transformation funding. We're working with our Department of Education on what that might look like. There may be some opportunities there for us as well with that. So more to come on the billing sustainability piece from that standpoint. But yeah, hopefully that kind of answered some of the question or provide perspective, at least on the Oklahoma side. So.
Thank you, Jared. We actually have a partner in Hawaii who are using, just another plug for the podcast, I think it's episode 4 that we spoke with them. But she mentioned that they didn't have space on the school, grounds to have the one of the schools have the clinic set up, but the students can access it pretty easily. But then that also meant that they could open it up to the wider community as well. So it kind of checked both boxes. It's like on a farm, and the guy who owns the farm let them use a room from what I recall. But I thought that was an interesting kind of solution of kind of hacking that, like, community clinic / school clinic / where can we find space? Let's just kind of stick a clinic in there. There's a question here about for Jared and Dr. Anderson. From Laurie, in Ohio, several counties do not have access to labor and delivery services outside of emergency departments. Is Oklahoma experiencing this? And if so, what work are you doing to create options or mitigate risks associated with home births, or to support ED staff in labor and delivery services? I thought that was quite interesting.
Yep, that's a wonderful question. And yes, Oklahoma does struggle with that. Dr. Anderson mentioned a little bit earlier. Obviously, that's a hot topic. We have obviously a residency program here with OSU. Dr. Anderson, I don't know, I might put you on the spot a little bit. I don't know how many residents that we have coming through that program.
Five every year.
Okay. 5 every year. Okay.
And it's a 5-year program, so.
Yeah. So, you can see we're trying to, obviously, it can be a challenge sometimes, especially in the state of Oklahoma, to kind of retain that. So for us in our program design, that's one of the things that we're really working on. So I've got this hand-drawn map here, and we really have strategically went through this kind of county by county to look at who's delivering, who's not, how far, how many miles, so we can at least have conversations and meet with some of those hospitals kind of in between to say, hey, if you've got an operating ER, great. What level of care or what level of scope do you have there? If we have a patient that needs to come there for an emergent, situation and they need to get stabilized, do you have what you need? Let's talk through that. Part of that too is just to open up the conversation like, hey, we're doing this. So do you have what we need? And are you prepared for that? Just to give a notification or kind of a heads up. If you see someone, here's what's going on, to call us. And so we're looking at it from the hospital perspective of are they prepared and ready if they don't deliver babies today, but also we're going to be working at it from the patient perspective of, hey, if you go in, make sure they call us, right? You're interested with us with your care, make sure they call us so we can immediately get engaged and to see what's going on. So anyway, and I'll full disclosure, I'll show you.
I want to see that. Yeah, exactly.
Here's the map. This is my handwriting. All of this, all yellow is counties that don't deliver. And so you can see down here is a big focus for us, and obviously in the Panhandle. So,
I think
great question. We're still working through that. Yeah.
I think it highlights, the partnerships that we try to create, just as Jared kind of spoke about, in everything that we do. And anytime I go and talk to one of our partnerships, again, all of our partnerships are unaffiliated with us. These are hospitals that are typically independent or are rural, underserved critical access hospitals that really have limited resources. So they're unaffiliated with OSU Medicine and OSU CHS. And so these are independent sites that we're going to talk to. And we really foster this partnership with these sites and really allow them, access to our providers by even just calling us. So even if it's an ER physician who needs to just call and talk to a hospitalist or a cardiologist or, an OBGYN, they have that opportunity to just have that partnership, that connection, just be able to ask a simple question or try to escalate them to the right location or even escalate their care to the right facility. We're there to kind of help them with that partnership. And that's really what we try to build with these locations, these facilities, just to help increase access to care there at their site.
And as we are kind of planning phase 1, 2, and 3 and on, right, we kind of get wider with kind of our bubble, that probably second and third phase are 2 to 3 tiers away from Tulsa. So you're looking at, probably over an hour and a half away, even sometimes maybe even longer. In those situations, that's going to become really critical for us to, like Dr. Anderson mentioned, to make sure that we've got a relationship with all of those hospitals around, just to say, hey, here's what's going on. Do you have training? What do you have there? What is it that maybe we can provide assistance or support to as well? And sometimes it may be, maybe a nurse practitioner or PA that maybe got limited training. Great, that's an opportunity for us to step in and maybe provide some education and support. So how do we do that too? So looking at all those, that's a great question. We're navigating that now. So.
Thank you both very much. I actually think, Jared, that secretly you're just doing a color by numbers.
That was my 14-year-old's color by numbers. I took hers, and so that's
There you go. I want to. Somebody has asked a question about fragmentation when dealing with proprietary technologies and systems. And I think this is especially a challenge when we're talking about virtual care, because obviously it's potentially another layer to be added. And the same is true for patients. If they're trying to sign up for an appointment, do they have to go to somewhere else? How do we streamline that process for them? So the question from Jay here is, how does the group see those barriers as being addressed from the perspective of rural care? And I know that that's not necessarily something that anyone's addressed specifically here today, but I think that there's some really interesting answers from the group, and would love to hear your thoughts.
I'm happy to talk about that from a provider perspective. Yeah, just, we have, Jared and I and OSU here, we've had, the experience over several years here now of adjusting our virtual care and telemedicine program here. And we've used lots of different virtual care entities and devices and technology. And, one of the main things that I found early on is that we do not get good usage if the technology that we use is not easily usable and accessible, both from a provider standpoint and from a patient or facility standpoint. So the nurse, the telepresenter on the other side, they're not going to utilize the equipment. The providers on the other side, they're not going to ask us for consults. The patients aren't going to want to see us if it's not easy to use. And so TytoCare was one of those devices that actually allowed us to really have easy access. Just the ease of its use was key. And we actually implemented it originally just in school-based, but once I found the technology, I was like, we're putting this in every site that we have. So it just allows that ease of use and allows both the control from the provider perspective, so I can help control the whole visit by showing the nurse how to utilize the equipment, but also just have the ease of use and ease of ability to connect from our standpoint.
The other thing I'll add to that.
Oh, go ahead, Jared.
I'm sorry, Lacey. I don't mean to interrupt you. Just real quick, I'll add to that from an EMR perspective. Our I guess EMR that we use on the virtual care side is web-based, and so wherever they're at, if they have, Google Chrome typically, they can get that. Then great, they can connect to us. We do a lot of everything, documentation housed in Andor Health, and then they're able to download that. Epic also has some Community Connect functionality as well that we use today, but it's a challenge. Like Dr. Anderson mentioned, all of our sites are not connected with OSU. They don't pump information back to us, so sometimes it is a little bit of a hand key information, but and then they can upload documents, etc. But yeah, web-based is kind of the best way that we found to kind of connect with all those that don't interface with our system. Sorry, Lacey.
Nope, I just want to stem off of what you gentlemen are saying. That's exactly what we've experienced up here too. And on the TytoCare aspect too, finding a product that provides good support to be able to troubleshoot firewall issues, bandwidth issues. Is the device connecting and syncing correctly, getting users logged in? That has been a game changer. We've used many platforms too over the years, and since moving to TytoCare in the early 2020 timeframe there, that has been huge. We've rolled that out into the 22 sites, and they're all using it. Another thing we find great success in is folks aren't going to use it if they're not bought into it, if they're not comfortable using it. So we train our staff annually on it, from the front desk to the nurses to the receiving providers, and we perform actual competencies on them to make sure that their skills are up to par. It also helps me on the tech side too to make sure the equipment's working so I can see them using it. I can watch them connect to the video, see the provider perform that exam. Plus, it gets the staff comfortable with each other as well, so they're able to kind of work and troubleshoot. Because if you've never been in a telehealth visit, it's hard to pitch it to a patient. I've actually made our staff here perform them on me so I can see what they're doing. So just learning it and using it is the best experience to promote it and continue to grow it, as well as something we found. So we offer and train staff a lot throughout the year to keep their skills up to par.
Yeah, and Lisa, you mentioned something about IT real quick, Joe. I don't mean to keep going on this, but we've seen a lot of different variations of IT staff and their knowledge base. And so for us, it's great to have. We kind of have we have an IT project manager, and her name's Heather. She's fantastic, but able to navigate some of the back end. Somebody mentioned firewalls, stuff like that. So having somebody that's able to navigate through that with your other rural hospital site, that's extremely important. So if you can invest in a really good resource that way, that's gonna go a long way for implementing training and getting that buy-in up front with other kind of rural location.
Thank you all. There's a question here about the telehealth dentistry, which I also have multiple questions about, but Lacey, we can maybe get into this separately. Did you run into any hurdles when it comes to state laws and scope of practice?
Actually, we're actually trying to expand our scope of practice right now to hopefully include our dental assistants, and they're working closely with the state right now in South Dakota. It's not as defined as you would see on the nursing aspect or the provider aspect when you're looking at the dental aspect of it too. So right now we keep it with our hygienists and our dentists and those licensed professionals, because a lot of the assistants we do, you can be certified, or we do on-site prem training to certify them. So we are looking to expand that and to allow more access, but South Dakota is just a little bit late, far behind, but that's something that our legislation is currently working on actually in amping that up. So we're excited to see that grow.
Awesome. I think that's all we have time for in terms of our audience questions.